I think the most exciting area is the area of new small molecules. The two that have been approved so far are both what we call B-cell receptor inhibitors, meaning that when you ligate the B-cell receptor on any B-cell, whether it's normal or malignant, you send a very strong proliferative and survival signal to that cell. So obviously, in the case of malignancy, you'd like to interrupt that signaling. There's a number of different kinases within the B-cell receptor pathway that could be targeted. The two drugs that are now approved by the regulatory authorities, both in the United States and Europe, are ibrutinib, which targets BTK, or Bruton tyrosine kinase, and idealisib, which targets PI3K delta. So again, these are both oral agents, and the way that they've been dosed in all of the trials so far is continuously, either until the patient loses their response or if they have a toxicity that necessitates them coming off the drug. Both of these drugs have been approved for relapse refractory CLL, and ibrutinib has as well an indication as initial treatment of patients with CLL and a 17p deletion. And that's actually based on the relapse refractory data with very little frontline experience, but because the relapse refractory data in 17p deleted was so much better than any published frontline data, I think reasonably the authorities gave the approval for frontline use in that population. It's not a big population because up front, patients with 17p deletion constitute only about 5 to 10% of previously untreated. Of course, where we see it frequently is in the relapse refractory population because it's a common clonal evolution. So I mentioned that both these drugs are approved for relapse. Ibrutinib is approved as a single agent. It's given at a dose of 420 milligrams once daily in CLL, which is actually a different dose than what's approved in mantle cell. There are a couple of similar things between the two drugs. They cause very, very rapid reduction in lymph nodes, extremely rapid. At the same time, if used as single agents, and I make that caveat because idealisib is actually approved in combination with rituximab. But if we look back at the single agent data for both drugs, you see this interesting pattern of response where you see this very rapid reduction in lymph node size, but you actually see lymphocytosis. So the lymphocyte count goes up initially. And a lot of the work looking at what's happening there was done by Jan Berger at MD Anderson, showing essentially that the chemokines that cause the cells to chemotax and adhere to the stroma are markedly decreased by these drugs, and so you have this initial efflux of the cells into the peripheral blood. The good news is that most people with CLL can walk around with lymphocyte counts in the hundreds of thousands and be entirely asymptomatic. So for the most part, we don't worry about it. It tends to peak at about 1 to 2 months and then come down over time. We see less of it with idealisib because when you add in a monoclonal antibody, you abrogate that lymphocytosis and you do get your responses more quickly. With ibrutinib and idealisib, one of the big advantages is that they're not myelosuppressive. So that in fact, probably the biggest complication of giving chemotherapy-based regimens to patients with CLL is myelosuppression and infection, in particular in a population that's already often immunosuppressed by virtue of their disease and or their prior treatments. So that complication more or less goes away, which is not to say a patient never gets an infection, but they can get an infection just from, again, their underlying issues rather than direct myelosuppression from the drug. Not only are these drugs not myelosuppressive, but they're very good at improving cytopenias. And in fact, you see that improvement in baseline hemoglobin or platelet count fairly early, which is interesting because you can see lymphocyte counts in the hundreds of thousands, and yet at the same time, the platelets and the hemoglobin are improving. And again, that's in marked contrast to what we see with chemo. So, and that's important because a frequent question I get asked now that these drugs are commercially available is, well, my patient has a baseline cytopenia, should I start at a reduced dose? Which is a normal way of thinking when all of your experience is based on chemotherapy. And the answer to that question, however, is no. You want to give the full dose because you want this fairly rapid improvement in the cytopenias that you see when you use the full dose. In terms of the Duration of response, we're talking in a fairly refractory population on the order of years, so these are durable responses. In ibrutinib, the only group in whom the median PFS has been reached within that relapsed refractory population are the patients with 17p deletion, where it was 28 months. And again, to put that in perspective, if you look at the best published data for frontline PFS in 17p, it's 11 months. So you can imagine then if in the relapsed refractory patients it's 28, that's quite impressive. And that's, I think, why the regulatory authorities also gave them a frontline approval, specifically in that cohort.